Hi, you're watching Nursinga. Today, as part of our summer lecture series, we're going to be talking about paramedic gynecological emergencies. And we're going to start out with an introduction to gynecology. So gynecology is the branch of medicine that deals specifically with female health maintenance and diseases, usually with the reproductive organs. As a paramedic, it's important to be familiar with both the internal and the external genitalia and the appropriate terms for your documentation as well as for your assessment. The internal reproductive organs are located within the pelvic cavity, and the external genitalia protect the openings. And these play an important role in sexual functioning, like the vulva and the pudendum. So the perineum is the diamond-shaped skin-covering muscular tissue that separates the vagina and the anus, and we oftentimes refer to kind of as the entire external genitalia as the peri area, but really the perineum is just between the vagina and the anus. The mons pubis, or the mons, is the fatty layer of tissue over the pubic symphysis, where there's the junction of the pubic bones. And so, if someone were riding a bicycle or fell against, a hard surface, they may have trauma to the mons pubis. The labia are separated into two sections. These are the structures that protect the vaginal and urethral openings. So we have the labia majora, which are two folds of fatty tissue that arise from the mons pubis and extend to the perineum, kind of forming the cleft, and they protect the inner structures of the vulva. So that's just kind of like the outer rim. The labia minora then are the two smaller, thinner folds of tissue. And during sexual arousal, these become engorged with blood. And again, it's easier to damage or lacerate those during non-consensual intercourse. The hymen is the thin fold of mucous membrane that forms an external border of the vagina, partly closing it, and that tends to be ruptured during the first sexual encounter or with use of feminine hygiene products, or just sometimes with activity. The clitoris is the highly innervated, like, bundle of nerves and richly vascular erectile tissue of the female that's located high in the prepuce. So that's the fold of the labial minora that covers the clitoris. And the urethra is the opening that drains the urinary bladder. In women, it's only 2 to 3 centimeters in length from the opening of the urethra to the actual bladder, which is why women become so prone to urinary tract infections, because the bacteria can travel easily from the external world into the internal world, or the bladder, more easily than in men. The internal reproductive organs, again, are located within the pelvic cavity, and these are things like our ovaries, our fallopian tubes, the uterus, and the vagina, and these are all essential to reproduction. So the vagina itself is the elastic canal of smooth muscle that is about 9 to 10 centimeters in length and connects the external genitalia to the uterus. And the opening between the vagina and the uterus is called the cervix, and the hole in the cervix is called the os, O-S. The vaginal walls are crisscrossed with ridges, which allows it to stretch during intercourse and during childbirth. And the primary blood supply is from the vaginal artery. The functions of the vagina include intercourse, and then birth, so it's the passageway for the infant during childbirth, and then it's also the outlet for menstrual blood and tissue during menses. The uterus itself is a hollow, thick-walled, muscular inverted kind of pear-shaped organ that connects with the vagina. It's usually only about 3 inches long and about 2 inches wide, or 7.5 centimeters long and 5 centimeters wide. So if you think about that, it's, you know, kind of smaller than your fist. It provides the site for fetal development. In a non-pregnant state, it's very flat and triangular, and it has 2 parts. So it has the body, or the corpus, and the cervix, which is also referred to as the neck. The fundus is the kind of uppermost portion of the uterine body, and during the kind of mid to later portions of pregnancy, we can use fundal height to estimate gestational age. So the top ridge of the uterus, you know, once it becomes palpable, can help us determine gestational age. The body of the uterus, so the corpus, the kind of the thick muscular area, has 3 layers of tissue that make up that uterine wall. So the endometrium is that innermost layer or lining, and that's the part that gets stimulated by hormones, estrogen and progesterone, every month, and it builds up and it gets thicker and thicker in order to receive the fertilized ovum or egg. If fertilization doesn't occur, then the lining degenerates and sloughs off, and the sloughing of the uterine lining is referred to as menses, or menstrual period. The myometrium is the muscle, and just like many of our other organs, obviously it's a nice thick muscular organ, it has to be in order to squeeze out a baby. So that's a nice thick middle layer of the uterine wall, and there are actually 3 layers of smooth muscle fibers that make up the myometrium, and it can contract in kind of different directions, which is interesting. And then there's the parametrium, which is the outermost layer of the uterine wall, and that's a serous membrane. So much like what lines your heart and your lungs and your abdominal cavity, the parametrium lines the uterus, and this allows surgical access to the uterus without risk of infection. The cervix, or the neck of the uterus, extends from the narrowest portion of the uterus to connect with the vagina, and it's very elastic, right? So it can stretch and dilate to open to a full 10 centimeters. So that's dilation, and then it also thins out. So like when you look at it on the picture here, you see like it's long and tight and closed, but it also thins out, which is called effacement. So it becomes very, very thin and then very, very wide in order to birth a child. The ovaries themselves are the primary female gonads, or sex glands, and they would kind of pair up with the male testes. They're almond-shaped and situated laterally on either side of the uterus in the upper portion of the pelvic cavity. So on the right-hand side here, you can see kind of a cutaway picture. On the left-hand side, you see the ovary kind of suspended in all of the ligaments, and you can see the fallopian tube and how that kind of lines up with it. The ovaries develop and release eggs, the ova, for reproduction, and women are born with all of the eggs that they will have for life when they're born, versus men that produce sperm throughout their life. The secretion of hormones, estrogen and progesterone, so again, those are the 2 big ones we're thinking about, estrogen and progesterone, are stimulated in response from follicle stimulating hormone, or FSH, and luteinizing hormone, or LH, that come from the anterior pituitary gland. So if you remember back to endocrine, you have the posterior pituitary gland that the hypothalamus, you know, puts stuff in, right? So ADH and oxytocin, and then you have the anterior pituitary gland that makes hormones that act on other parts of the body. So FSH and LH are secreted from the anterior pituitary gland and help with, you know, preparation for fertilization, for having ripened eggs, as well as for implanting a fertilized ovum if that occurs. And then because of the peaks and valleys in those hormones, it also causes menses if implantation of a fertilized egg does not occur. The fallopian tubes themselves, sometimes referred to as uterine tubes, are thin, flexible tubes that extend laterally from the uterus and curve up and over each ovary on either side. So you can see they're almost like arms that stretch out with little fingers that come over the edge, and those are called fimbriae. And as the egg is released from the ovary, it is kind of caught up by those fimbriae and end up in the fallopian tube. And oftentimes fertilization occurs within the tube itself, and then implantation should occur ideally within the endometrial lining. So the fimbriae conduct the egg from the space around the ovaries into the uterine cavity via peristalsis. So just like in your GI tract, you have peristalsis. The same thing is kind of occurring within the fallopian tubes. Your menstrual cycle is a monthly hormone cycle that is kind of different for every person, but on average lasts about 28 days. Again, it prepares the uterus to receive that fertilized egg. A couple terms that you should know: menarche is the onset of the menstrual cycle, and that's where it establishes female sexual maturity, typically between the ages of 10 and 14. And not something that we worry about too much in the pre-hospital setting, but early or late menarche sometimes is correlated with different types of cancers or reproductive issues. A normal menstrual cycle is what is normal for the woman in question. So some people have shorter cycles, some people have longer cycles, some people have irregular cycles. So you want to compare what's normal to them versus what's happening to them at that point in time. Regardless of how long, though, their cycle is, the period of time from ovulation to menstruation is always 14 days. So the person will always ovulate 14 days before they start their period. From puberty to menopause, the female sex hormones, estrogen and progesterone, control the ovarian menstrual cycle, pregnancy, and lactation. So you need to know these phases. The proliferation phase is the first 2 weeks of the menstrual cycle, and it's dominated, as you can see in this picture, by estrogen, which causes thickening of the uterine lining, the endometrium, and that becomes engorged with blood. So estrogen thickens the endometrium and it becomes engorged with blood. So you've got 3 E's that you can kind of put together there. In response to the surge of luteinizing hormone at day 14, ovulation or release of the egg takes place. And then once during the menstrual cycle, the follicle reaches maturation and ruptures, discharging its egg through the ovary's outer covering into the fallopian tube, as we talked about. The ruptured follicle develops a corpus luteum, or a small yellowish body of cells, which produces progesterone during the second half of the menstrual cycle. So it's actually the ovary and the healing corpus luteum that produces the progesterone. Again, if the egg is not fertilized, the corpus luteum will atrophy about 3 days prior to onset of the menstrual phase. If the egg is fertilized, the corpus luteum will produce progesterone until the placenta takes over that function. The cilia, or the fimbriae, on the ends of the fallopian tube draw the egg into the tube and sweep it towards the uterus. If a woman has had sexual intercourse within 24 hours of ovulation, fertilization may take place. If the egg is fertilized, it implants in the thickened lining of the uterus where the fetus develops. And if it's not fertilized, then it just passes into the uterine cavity and is expelled. So that's all in that kind of proliferative phase. In the secretory phase, again, if the egg is not fertilized, the woman's estrogen levels drop sharply while the progesterone levels dominate. Uterine vascularity increases during this phase in anticipation of implantation of the fertilized egg. And in the ischemic phase, if fertilization does not occur, estrogen and progesterone levels both fall, and vascular changes cause the endometrium to become pale and small blood vessels rupture. Then this leads to endometrium shed, along with the discharge of blood, mucus, and cellular debris known as menstruation. So day 1 of this cycle is the first day in which bleeding begins and typically lasts 3 to 5 days, although again that can vary from woman to woman. So the average blood loss is only about 50 milliliters, although sometimes it seems like it's a lot more for some women. And absence of a menstrual period in a woman in childbearing years between the age of 12 and 55 who is sexually active and normally has regular periods should raise suspicion of pregnancy. So amenorrhea, or lack of menstruation, in somebody who should be having a period should be considered a pregnancy until otherwise proven to be something else. There are some syndromes that you should know about that are associated with hormone changes. There's premenstrual syndrome, or PMS, which are physical signs and symptoms prior to the period, so premenstrual, before your period. And those tend to be things like breast tenderness or engorgement, transient weight gain or bloating, excessive fatigue, cravings for specified foods, migraine headaches, and emotional responses. This is very different from premenstrual dysphoric disorder, or PMDD. This is symptoms of severe depression, irritability, and tension before menstruation. People typically go on antidepressants or sometimes even almost antipsychotics for PMDD. So our SSRIs and our SNRIs have been used with some success in PMDD, but women have reported homicidal ideation with PMDD versus just, feeling tired and emotional with PMS. Menopause is the expected cessation of menses when we have cessation of ovarian function and cessation of estrogen secretion. And that typically occurs on average around age 52. Menstrual periods usually continue to age 45 to 55 and begin to decline in frequency and length until they ultimately stop. The climacteric phase is the end of reproductive life. So somebody who is menopausal is also referred to as being climacteric. A decrease in estrogen levels cause hot flashes, night sweats, mood swings during menopause. Hormone replacement therapy, such as estrogen or estrogen and progesterone, is sometimes prescribed to relieve these complaints, but is also estrogen replacement therapy has been tied to an increased risk of certain cancers, and so it cannot be used for all patients. So let's talk a little bit now about history and physical exam tailored to the GYN patient. Abdominal pain in women who in childbearing years is often due to problems of reproductive organs. So it's going to be really important for you to do a complete primary assessment and proceed with a good secondary assessment. You're going to need to ask specific questions pertinent to reproductive function and dysfunction and assess the patient's emotional state. I can't stress enough how important it is to use professional verbal and nonverbal communication. And if you are acting uncomfortable and inappropriate, they're going to feel very uncomfortable and are not going to be forthcoming with information with you. The most common complaints are abdominal pain and vaginal bleeding in the gynecologic patient. So when you're taking a history, if the chief complaint is pain, make sure you use the OPQRS mnemonic. Dysmenorrhea is severe discomfort during menstrual periods. Dyspareunia is painful sexual intercourse. And determine associated signs and symptoms. So always make sure that you're asking kind of related information. Be sure to ask about bleeding or discharge, and ask about the color, the amount, the frequency, and any odors with vaginal bleeding or discharge. In your sample history, L can stand for last menses as well as last meal, and those are important for the potential surgical candidate that you get both of those. You want to obtain a good OB/GYN history. So gravida stands for the number of times the woman has been pregnant including this one if she's currently pregnant. Para or parity stands for the number of deliveries the person has had. And AB or abortion is any pregnancy that ends before 20 weeks of gestation, regardless of the cause. And so it doesn't matter if it was a miscarriage or a medical or surgical termination of the pregnancy. Then we want to obtain a really good gynecologic history. So we want to ask about ectopic pregnancies, a history of sexually transmitted infections, a history of cesarean sections or surgery, like pelvic surgeries such as tubal ligation, any surgical terminations of pregnancy, and dilation and curettage or D&C procedures. People also may have had surgery on the cervix itself, such as a colposcopy or a LEEP procedure or a cone biopsy. Just write those down and include that in your report. Prior trauma to the reproductive tract is important to know about as well. And if they're sexually active, if they have pain or bleeding during or after sexual intercourse is important to know. So that would be like a kind of a pertinent negative. Ask whether their last period was of normal length or heavier or lighter than usual. And when you ask about when was your last menstrual period, remember that you want the first day that they started bleeding. So if they say it was about 3 weeks ago, you want to clarify, did it end 3 weeks ago or start 3 weeks ago? Because it may have started 4 weeks ago and ended 3 weeks ago. When we're talking about the flow for women, like the heaviness of a menstrual period, the easiest way to estimate menstrual flow is to ask the number of pads or tampons used, like per day or per hour. And then you can ask, if that was normal for them. Ask about the regularity of their periods and if they use birth control, what form they're using. And if you suspect pregnancy, inquire about signs, late or missed periods, breast tenderness, bloating, urinary frequency, nausea, or vomiting. And I do want to point out that morning sickness is kind of a misnomer. People who are pregnant could have nausea at any time during the day, not just in the morning. Assume any missed or late period is due to pregnancy, even though the patient may deny it. Contraception or prevention of pregnancy, or the attempt to prevent pregnancy, takes many forms with variable degrees of effectiveness. Some people use the withdrawal method or the rhythm method, and as a joke, we often call it the rhythm method of getting pregnant and not of contraception. You should be familiar with the various forms and their method of action and reliability. And, we know that, honestly, abstinence is the only reliable form of birth control. The other pertinent negatives you should ask about would then be things that could be other things, signs and symptoms that could cause abdominal pain. So like diarrhea, could this be gastroenteritis? Urinary symptoms, urgency, frequency, hesitancy, dysuria, so painful urination, could this be a urinary tract infection? And then dizziness, lightheadedness, syncope. Now those are really important because if you're worried about pregnancy and the patient's having abdominal pain, especially if they're having abdominal pain and bleeding, and you're worried about an ectopic pregnancy, bleeding is a very late sign, which means then that already has ruptured. And if they're experiencing any dizziness, lightheadedness, or syncope, they could be experiencing hemorrhagic shock. During your physical exam, it's really important to maintain privacy and modesty as much as you can. Perform your normal head-to-toe assessment, remembering that mental status is a key indicator of cerebral perfusion. You inspect, auscultate, and then palpate the abdomen. And the reason that you look at it first and then listen before you touch it is because palpation actually increases bowel sounds, and it might change what you find for findings. So it's important to inspect and auscultate before you palpate. If pregnant, the fundus is palpable at 3 months above the pubic, or at the pubic symphysis at roughly 12 weeks. And then at roughly 20 weeks at the umbilicus. And that's about when we can start measuring with our tape to determine fundal height. Visualize the perineum only to expect for trauma and what we call RETA. So RETA is redness, edema, ecchymosis, discharge, and approximation of wounds. So like if the person has had a sexual assault or something like that, then we're just looking to make sure that they're not hemorrhaging. Okay. Bleeding amount. Do not pack the vagina. Instead, you can put a pad on the perineum. If the person, again, if it is a sexual assault, don't, remove or throw away clothing. Anything you do take off needs to go piece by piece in individual paper bags and labeled. And if you put any gauze or pad or anything like that on there, you want to save that if for some reason you have to change it. Obtain vital signs and monitor for trends. So remember that your physical exam is going to be very limited in the field, and their comfort level should guide your actions. Be as professional as you can and explain all procedures thoroughly to help alleviate fear. Their level of consciousness is going to be your best indicator of their stability, of their status. So pay particular attention to things like their general appearance, the color of their skin, their mucous membranes, remembering that cyanosis and pallor may indicate shock and a flushed appearance may indicate fever. If you're going to palpate the abdomen in someone who has abdominal pain, remember to just gently palpate the abdomen and then document and report any masses, distension, guarding, localized tenderness, or rebound tenderness. Your management begins with routine patient care. And so really, what does that mean? So we focus primarily on supportive care, position of comfort, ABCs, making sure that you're continually assessing them for conditions or changes in their condition. You rely on your primary assessment to guide the need for oxygen therapy, IV access, analgesia. Administer oxygen or assist ventilations as necessary, and IV access and fluid replacement are usually not indicated for the GYN patient unless you have something really critical going on. If there's excessive bleeding or signs of shock, establish one large bore IV and administer normal saline. Do not pack dressings inside the vagina, ever. Discourage use of tampons to absorb blood flow, and count and document the number of sanitary pads used. So make sure that you're titrating your oxygen to maintain a saturation of 94 to 99%. Place the patient on all monitors, EKG, SpO2, end-tidal CO2 if you're worried about shock or hypoperfusion. 12 lead if the patient has acute coronary syndrome, glucose if there's altered mental status, right? Fluids to maintain a blood pressure of 90 systolic or a MAP of 65. Treat your symptoms and your findings appropriately and then transport to the appropriate facility. Don't get distracted by the fact that this is a GYN complaint. Treat them as you would any other medical patient. Position of comfort or left lateral recumbent position, supine with knees bent, decreases tension on the peritoneum, and that may help them. So, almost like the fetal position or with the knees drawn up may make this patient more comfortable. Opiates are definitely the right choice for pain management. IV Tylenol is also great. And then psychological support is also very helpful to help keep them calm and provide reassurance. Remember that significant vaginal bleeding and abdominal pain may be a surgical emergency, so do not delay transport. So to summarize, a vast majority of gynecological emergencies will present with abdominal pain, vaginal bleeding, or both. It's important to obtain a detailed history, including whether the patient is sexually active or not. Because of women's short urethras, they are more prone to urinary tract infections, especially following periods of prolonged sexual activity. Additional causes of abdominal pain include pelvic inflammatory disease and ectopic pregnancies. Treatment usually includes supportive care. IV therapy is necessary to maintain a normal blood pressure or normal MAP. And if the patient does not want to divulge information, treat for the worst case scenario. Do not push. Often, especially in young teens, patients will deny having sexual relationships even though they may indeed have one. When dealing with non-traumatic vaginal bleeding, the best historian really is the patient, and that may mean that you need to get them away from parents or anyone else who they may not want to hear what they have to say. Menarche occurs as early as age 10 and beginning of further development into sexual maturity. That means that you could have a pregnant 10-year-old. Initial cycles may have slight variation of dates and eventually lead to a regular 28-day cycle. The patient should be able to tell you where she is in her cycle and whether this type of bleeding is normal. Never pack anything into the vagina. You use a 5x9 or trauma dressings or ABD, whatever, to absorb blood flow and keep any tissue or clots that are passed. Keep the patient as comfortable as possible. Treat hypotension with IV fluids and oxygen therapy. If there's an injury secondary to an assault, keep in mind the importance of preservation of evidence, and remember to make the patient care your #1 priority. Thanks for watching, and I hope you have a great day.